So it is actually a public health program for the early identification of certain disorders among newborns that can lead to mental retardation and death if left undetected and untreated. So the newborn screening in the Philippines actually started in June 1996 and was integrated into the public health delivery system with the enactment of the Republic Act 9288, also known as the Newborn Screening Act of 2004. This is actually a favorite question during the board exam. So take note, Newborn Screening Act of 2004. So this is an act promulgating a comprehensive policy and a national system for ensuring newborn screening. So currently, there are 7 operational newborn screening centers in the country, and all samples collected are sent and processed into these centralized laboratories. We have one in NIH of UP Manila. They cater samples collected in NCR and regions 4B and 5. We also have one newborn screening center in Central Luzon in Angeles City, Pampanga, which caters to samples in regions 3 and CAR. And we also have one in Southern Luzon in Tanawan City, and they actually caters the samples from region 4A. We also have one in Northern Luzon in Ilocos Norte, which caters sample from region 1 and 2. And we have the latest one in Central Visayas in Mandawi City, but they only cater or serves region 7. Region 8 is actually under the NSCD, Newborn Screening Center Visayas in Iloilo. So, Iloilo caters region 6 and 8. So, di pa tayo under the Central Visayas. So, still, we are under Iloilo Newborn Screening Center. So, for Mindanao, we have one in Southern Philippines Medical Center in Davao. So they caters all samples from regions, all regions in Mindanao. Okay, so this newborn screening center is actually unique because it does not only operate as a laboratory but also has a follow-up program. They have that short-term follow-up program and a long-term follow-up program. So for short-term follow-up program for patients, so this means that after screening test, then if it turned out to be positive, they still have to confirm it. And if it's negative, then hanggang dyan lang sila sa short term. But if the confirmatory test will turn out to be positive, these patients will be endorsed to the long-term follow-up. Okay, so we are the ones actually, long-term follow-up is actually, the name currently is under the NBS Continuity Clinic. Those patients who are confirmed metabolic disorders. Okay. So NBS was actually introduced by a group of pediatricians and obstetricians from 24 Metro Manila hospitals in June 1996, and as a research study, and was adopted by the Department of Health as one of its program in 1999. And currently, the newborn screening is now available in more than 7,000 health facilities and rural health units. So 7,000 plus screening facilities. So why is newborn screening important? So actually, all babies look normal at birth, and babies having these disorders cannot be identified by physical examination alone. And one will never know that the baby has a disorder until the onset of signs and symptoms, which may already be irreversible at the time of diagnosis. The babies may be mentally retarded, or in worst cases may even die. So the newborn screening aimed at the early identification of infants who are affected by certain genetic or metabolic disorders. Early identification and timely intervention can lead to significant reduction of morbidity, mortality, or reduced disabilities in affected infants. So with newborn screening, 33,000 newborn babies every year, or 88 newborns every day, or 4 babies every hour will be saved from mental retardation and death. Diba? Ang dami nila. So to save more babies, the Department of Health Advisory Committee on Newborn Screening has approved the implementation of the expanded newborn screening. So before year 2014 ended, the expanded newborn screening, which is screens for 23 additional disorders was implemented in our country. So from 6 to additional of 6, so a total now of 20, additional of 23 disorders, so a total now of 29 disorders. Okay, so aside from the 6 conditions in the previous panel, we have the congenital hypothyroidism, congenital adrenal hyperplasia, galactosemia, phenylketonuria, MSUD, J6PD deficiency. So there are now 23 additional disorders. This will actually provide opportunities to significantly improve the quality of life of the affected newborns through facilitating early diagnosis and early treatment. So we have now 29 disorders. So over the past decade, we are actually using the tandem mass spectrometry and has become a key technology in the field of NPS. It has replaced the classic screening technique of one analysis, one metabolite, and one disease with one analysis, many metabolites, and many disorders. So through tandem mass spectrometer, many analytes associated with specific IEMs can be measured from one blood spot in only 90 seconds. Only 90 seconds. So, yun yung pinapadala natin na blood sample, yung, di ba, sa filter card. O, yan. So, dati kasi parang isang cut ng filter card na yan, isang disease din. Pero ngayon, marami na siya. From one cut to several disorders. Okay, so this is just to show you the machine that we are actually using. So for metabolic disorders, we are using the tandem mass spectrometry machine. And then for hemoglobinopathies, we are using the high-performance liquid chromatography. So again, just to clarify, newborn screening and expanded newborn screening is not a diagnostic test. They do not screen for Down syndrome or ADHD. And ENBS reference values are calculated for newborns less than 28 days, and hence screening of babies who are more than 28 days, results should be interpreted with caution. Maraming cases ito magtatanong sa atin, Doktora, pwede pa po bang magpa-newborn screening kahit 6 months old na? So ang sagot natin always is, yung value natin is actually calculated based on less than 28 days old na babies. So, parang it's not, kumbaga, it defeats the purpose then if we usually do that newborn screening beyond 28 days, diba? Ideally, it should be taken 24 hours after birth. Ayan. So, ideally done immediately 24 hours at birth by heel-prick method. And the blood sample should be in the laboratory not later than 4 days. And this was designed to provide affected babies with timely interventions, thus reducing the death and associated disabilities. So by the way, the filter card has a distinctive mark, orange sticker located at the lower portion of the filter card. So there are some facilities pa kasi with that previous, the traditional NBS, not yet the expanded newborn screening card. So with expanded newborn screening card, there is that sticker, that color, orange sticker. Okay, so kaya makikita nyo at a distance na yun ay expanded newborn screening card. So we also have what we call the golden period, and the most important and widely accepted goal of newborn screening is to improve the health outcomes in the screened population of the newborn. So given this goal, screening makes sense only if early detection and treatment will lead to a better health outcomes than would be possible if treatment were delayed until the condition became symptomatic. So newborn screening time is actually gold. This is what we term as the golden period, being defined as a critical time or age beyond which, if no appropriate treatment is given, signs and symptoms are irreversible. Okay, so for it is really critical to screen babies as early as possible to prevent the negative effects of this disorder. So a baby is best treated for congenital adrenal hyperplasia, likewise with MSUD before the 7th day of life. And if newborn screening is done 1 week after birth, the baby may already be in crisis or may even die. So parang huli na tayo doon. So for CH naman, the golden period is we have to treat the patients within 2 weeks. PKU, we have to treat the patient or intervene or give some special milk formula within 3 weeks. GAL also 3 weeks, and yan, MSUD, mas okay sana kung within 7th day of life. Kaso lang, with our current situation, there are some delays on the transit of the filter cards going to Iloilo, especially in Iloilo because the blood will be transported either via Maynila or Cebu. So medyo nadidelay yung transit time natin. Usually ngayon nasa 7 to 10 days. Tapos kung sa nursery pa magpo-pull ng ipapadala na card, kunyari not every day sending that blood sample, so mas lalong nagtatagal. Kaya sa nursery, kailangan mag-send ng everyday. Diba? Oo. So, for those who are assigned at the nursery, please always send the blood samples immediately. Okay? So, avoid pulling up samples. So, this is just to show you the official result of expanded newborn screening. So, hindi naman lahat nakalagay ang 29 disorders. They are actually grouped into disorders. They have that main disorders, and then under that may mga kanya-kanyang na sila pangalan. But for reporting purposes, they do not report that pa-isa-isa. They are grouped into main disorders, metabolic disorders. Okay, so this is just another sample result showing us a positive result. Okay, on screening. This is the case of 3-MCC deficiency. Okay, so what are the disorders being actually tested by the current expanded newborn screening? So we have the standard NBS panel. We have the previous ones, the congenital hypothyroidism, CEH, galactosemia, phenylketonuria, MSUD, and the G6PD deficiency. And then add on to that, we have the hemoglobinopathies. So marami yan, alpha thalassemia, hemoglobin C, D, E, anthrates, and alpha thalassemia, beta thalassemia, and all. There are 5. So but they are collectively kumbaga, tinatawag na as one. Okay? So, for amino acid disorders, we have 5. Dami nila, homocystinuria, MSUD, phenylketonuria, tyrosinemia, and hypermethionemia. We also have organic acid disorders, and urea cycle disorders. Madami din yan. Yun, 3-MCC, the propionic acidemia, methylmalonic acidemia, glutaric acidemia type 1, isovaleric aciduria, and ketothiolase deficiency. Okay, so you also have your FAOD, the fatty acid oxidation disorders. Madami din yan. We have 7. The medium chain, acyl-CoA, dehydrogenase deficiency, the very long and medium chain. Madami din yan. CPT type 2, carnitine deficiency. Dami yan. Okay? So, I actually do not expect you naman to memorize everything, di ba? But at least familiarize with all those names of disorders. So other disorders included in the panel also are cystic fibrosis, biotinidase deficiency, galactosemia, G6PD, UCD or the urea cycle defect, the citrullinemia, and adenylosuccinic acidurias. Okay? Just familiarize yourself, but pwede naman hindi natin i-memorize yan, nakakalungka kasi yung mga terms na yun. Okay, so individually, these metabolic disorders are actually rare, but collectively make up a significant number. And of course, no disease is actually rare if it affects someone you love, diba? So we really have to understand the feeling of those parents, of those individuals who has a confirmed, lalo na pag confirmed positive results of metabolic disorders. So as I said, expanded newborn screening is not a diagnostic test. So it only provides a presumptive screen positive result, which means that babies who test positive for a condition are referred at once to a specialist for follow-up testing should be done to confirm the diagnosis, since false positive are always possible. If the diagnosis is confirmed, then the child must then be linked to an appropriate or long-term treatment and management. So if negative on confirmatory testing, no further testing may be done and patient will be referred back to the health facility for continuity of care. So why do we need to do confirmatory testing? So biochemical testing, of a plasma amino acid analysis, this is analysis of building blocks for protein. And we also have to check for the plasma acyl carnitine profile, which analyze of how the body processes the fats, and urine organic acid analysis, which analyze of intermediary metabolites or lipid, amino acid metabolism, and the quantity of ketones. So of course, the confirmatory tests are all free. Okay. So these are some of the confirmatory tests for the disorder. So for congenital hypothyroidism, which is the second most common metabolic disorders, first is the G6PD deficiency, second is congenital hypothyroidism. So for CH, the confirmatory test, we have to send for a serum using the red top. So you will expect if it's a confirmed positive case of congenital hypothyroidism, elevated TSH level and a low FT4. For CEH, we have to send sample using also serum, using red top, plain top test tube. So 17 OHP and then low sodium potassium usually, especially in those patients on metabolic crisis, and then high potassium level and usually low or normal random blood sugar. PKU, a positive NBS result will show us an elevated phenylalanine level, and we have to repeat it, a blood spot or request for a urine specimen. And usually they test for urine terins, substates. And then for galactosemia, confirmatory test, high gall metabolites with no activity on gall. For MSUD, you will expect an elevated plasma amino acid analysis of your leucine, and then you also have to request for an urine organic acid analysis. For G6PD confirmatory test, so a low level of your glucose 6-phosphate dehydrogenase. Okay, using whole blood, using EDTA. And then organic acid disorder, specimen is plasma, heparinized tube or red top, and then we also have to send sample of urine for plasma amino acid analysis and urine organic acid analysis. For amino acid, it's also a plasma amino acid analysis and urine organic acid analysis, both plasma and urine, so almost the same here. And then for fatty acid disorder, confirmatory test of plasma acyl carnitine analysis and urine organic acid analysis. And for hemoglobinopathies, capillary electrophoresis, DNA analysis. Medyo matagal-tagal ito, ang DNA analysis. Kasi titignan yung mga gene mutations, gene deletions, and all. So CBC of patients and also of parents. Ang confirmatory is actually free, diba, for our patients. But there are some parents din na who would want to subject themselves for confirmatory testing, kasi lalo na pag gusto nila malaman kung sino yung may disorder, so they have to pay for themselves. So it's not free. So actually it's quite expensive, lalo na pag mga DNA analysis. I think nasa 5,500. Pero yung mga urine organic acid analysis, plasma analysis actually cost like 15,000 to 20,000 per test. It's quite expensive, but it's for free for our patients. So what are the prevalence rates as of the moment? So as of December 2020, actually the G6PD deficiency topped the list, followed by congenital hypothyroidism. So it's quite common. G6PD, the rate is actually 1:60. So you can just imagine, if you have a deliveries per day of 60 babies, so among those 60 babies, may usahiyan na magpa-positive ng G6PD. Then followed by congenital hypothyroidism of 1:2,722. This is our local data, national and local data combined. So congenital adrenal hyperplasia, 1:20,000. So quite common also. And then the MSUD, quite common also. So medyo marami-rami na rin mga patients natin with the expanded newborn screen. So marami-rami na rin ang na-save na babies. So I'll be talking about then the basic concept of inborn errors of metabolism. So actually, diagnosis of metabolic disorders does not actually require extensive knowledge of biochemical pathways. So an understanding of the basic general principle that applies to all metabolic disorders is far more important. So normally, each metabolic pathway consists of a series of biochemical reactions facilitated by an enzymes. So metabolic pathways are often considered to flow in one direction. So the product of one reaction are the substrates for subsequent reactions and so on. So to simplify, substrate A acted upon by an enzyme will generate product B. So this in turn will be used as a substrate for another enzymatic reaction. So medyo simple lang, diba? So A plus enzyme equals B. Okay? So that's one flow direction. So with inborn errors of metabolism, most are due to defect in an enzyme, which actually results in a blockage of metabolic pathway. So the effects are actually either due to toxic accumulations of substrates before the block, or defects in energy production caused by deficiency of a transformed products beyond the block, or a combination of these two metabolic deviations. Okay? And then, so generally, the management of metabolic disorders are guided by the principles either due to decrease in the substrate availability kasi accumulated before the block, or an increase in the disposal of the toxic metabolites beyond the block, and then increase in enzyme activity. Okay, so or we may provide deficient metabolites. Okay, so either of the four, kung saan tayo dyan ang available na treatment. Okay, so almost all metabolic disorders are actually has an autosomal recessive pattern of inheritance, which means that the patient inherits two mutated genes, one from each parent. So the parents are usually carrier of that disease, and they typically do not show any signs and symptoms of that condition. So they do not know actually until they have that baby who turned out to be positive. So if both parents are carriers, there is a 25% chance of a child inheriting both abnormal genes and consequently developing the disease. So there is a 50% chance of child inheriting only the abnormal gene, one abnormal gene, and one being a carrier. So like the parents, and there is a 25% chance of a child inheriting both normal genes. Okay, so 25, 50, and 25 normal. 25 affected, 50% carrier unaffected, and then 25% with full-blown signs and symptoms of the disease. So, himay-himayon ko lang ng konti. So, amino acid disorders, it's inability to break down certain amino acids properly due to a genetic deficiency in certain enzymes. And amino acid plus toxic substances build up in the body and cause problems. So, this is the table showing us the amino acid disorders with the defect and deficiency and the concomitant management. So, hypermethionemia, we are actually providing special milk formula with a low methionine diet. Homocystinuria, we have to supplement them with pyridoxine, folic acid, vitamin C supplementation, and of course, a low methionine diet. MSUD, we are providing with special milk formula, the BCAD, and then phenylketonuria, special milk also, diet-free from phenylalanine or phenyl-free milk formula. Tyrosinemia, dietary restriction of phenylalanine and tyrosine. Okay, what about for organic acid disorders? So children with organic acid disorders cannot break down proteins properly due to a genetic deficiency in certain enzymes. So as a result, harmful substances build up in their blood and urine, which can affect their health, growth, and learning. Okay, so for 3-MCC, protein-restricted diet, glycine supplementation, carnitine supplementation. For beta ketothiolase deficiency, so we have to instruct the parents to avoid fasting, low fat, or high carbohydrate intake. So what about the fatty acid oxidation disorders, inability to properly break down fat from either the food they eat or from the fat stored in their bodies due to genetic deficiency in the enzyme. So the first episode arises following illness or fasting. Dito siya nakikita usually. So for carnitine uptake defects, so we have to supplement it with carnitine and then dietary restriction of fats and avoid, of course, fasting, especially for those with MCAD, medium chain acyl-CoA dehydrogenase. So during illness, we have to provide them with IV glucose. So what about for BLC-ADD and LCH-AD? So we have to avoid metabolic stress, we have to treat infection immediately, and avoid prolonged periods of fasting. Yan, parehas sila na dalawa. Okay, so what about TFT? Ganun din, avoid metabolic stress and long periods of fasting, reduce long-chain fat intake, supplementation with medium-chain triglycerides and fat-soluble vitamins. So for urea cycle defect, citrullinemia, dietary restriction of protein, supplementation of protein-free formula, and then for arginosuccinic acidemia, so we have to provide them with sodium benzoate or arginine supplementation. Okay, so to better understand this metabolic disorder, I will be presenting selected cases of metabolic disorders. So generally, IEM are actually a diverse class of genetic disorders involving abnormalities in biochemical cellular processes. This can either be due from a gene level defect or on the protein level defect or on the metabolic level. So either way. So babies with metabolic disorders usually are normal at birth. So what are some of the clues that we might be dealing with metabolic disorders? So catastrophic illness or exaggerated response to an intercurrent illness, acute encephalopathy with hypoketotic, hypoglycemia, ketosis, acidosis, or hyperammonemia, in a condition resembling that of an infectious disease but no organism is isolated. This is our typical case of like a very septic patient, tapos pag nag-blood culture ka naman or any culture, parang lahat naman negative, na-cover mo na ng antibiotic, pero hindi pa rin nag-i-improve, in think of a possible inborn error of metabolism. And then, unexpectedly poor response to treatment of an illness presumed to be acquired, and other neurologic features, development of delay, regression, seizures, sleepiness, blindness, stroke, and movement disorder. So, there are those patients na seizure sila, hindi naman sila makontrol ng mga any anticonvulsants. So, we also have to try to investigate for a possible metabolic disorders. Okay, so for case number 1, so a 9-day-old neonate and remarkable maternal and birth history at fourth day of life. She manifested with forsac, vomiting on the 5th day of life. Patient had seizure, and on pertinent PE showed ambiguous genitalia. Labs taken, sodium of 128, potassium of 6.3, hypokalemic, and then RPS of 2.6, hypoglycemic. So, what do you think is this case? Sinong sasagot? Tatawag ako. Ira, anong case ito ay? Ira?
Hello, Doc.
Sige, wala yata. Sige, anong case ito? This is a common case. 9-day-old neonate and remarkable maternal birth history, fourth day of life, manifested with poor sac, vomiting, fifth day of life, nag-seizure, and then on physical exam, you noted an ambiguous genitalia, hyperpigmentation of the skin. So you have your laboratory test with you, hyponatremic, hypokalemic, hypoglycemic. So what do you think is this case? Huh?
CAH, Doc?
Are you sure? Yes, this is a case of a CAH, okay? Congenital adrenal hyperplasia, 'di ba? O, typical siya na ambiguous genitalia. Okay? So, this is a metabolic disorders, endocrine disorders specifically. So, um, the gland which is actually involved are the adrenals, okay, specifically the adrenal cortex. So the most common cause is 21 alpha hydroxylase enzyme deficiency, which leads to varying degrees of cortisol and aldosterone deficiency. So you are correct, Ira, this is a case of congenital adrenal hyperplasia. So based on the laboratory results, I think we are dealing here with a salt wasting type of congenital adrenal hyperplasia. Okay, so just a quick review. The synthesis of aldosterone, your cortisol, and adrenal androgens occur in separate zone of adrenal cortex. Magagaling ang mga ano dito, ang mga intern. So, in zona glomerulosa, di ba, we have the mineralocorticoids, zona fasciculata, which is responsible for the production of glucocorticoids, and zona reticularis, responsible for the adrenal androgens. Okay? So please don't look hard on this slide. Nakakaloka siya. This is just a simple presentation of adrenal steroid biosynthetic pathways. So an appreciation of these pathways will serve as the basis for understanding the different forms of congenital adrenal hyperplasia. So there are several types of actually etiology of congenital adrenal hyperplasia, but the most common ones like more than 90% of cases are caused by 21 hydroxylase deficiency. So with this deficient enzyme, there will be accumulation of substrates before the block. So, diba, as you can see, we have the pathway for aldosterone, pathway for cortisol, and pathway for estradiol. So, if the deficiency is 21 hydroxylase, Ayan. Pag may block ng 21 hydroxylase, so the production cannot proceed down the level. Okay? So what happens is there will be accumulation of the metabolites above the block, the 21 hydroxylase deficiency, this pathway. Okay? So this 17-OHP will accumulate. Actually, this is the substrate being tested by the newborn screening. Our newborn screening, di ba? Nakikita nyo, positive, more than our normal value for 17-OHP for newborn screening is actually less than 40. Okay. So any level more than that will be released by the newborn screening as positive for CEA, 17-OHP, which is actually elevated. Okay. So they will request for a confirmatory test. So this is the 17-OHP. This is also a common, a favorite question during the board exam. Pati na rin sa specialty board exam ng PTS. Okay, so take note. Ayan. So what happens is that there will be accumulation of your 17-OHP, and all this substrate before the block of that pathway will be converted, will be shut off to this level, to this pathway, the aldosterone, the androgen level. So that is why if you have a female case of CEH, nakikita mo siya as ambiguous genitalia. Pero pag boys, you will not expect an ambiguous genitalia, pero makikita mo maitim yung scrotum niya, mahaba yung penile length niya, parang extraordinary malaki yung genitalia pag boy. Okay? So, for those babies naman with ambiguous genitalia, na hindi naman siya CEH, that's another disorder. Disorders of sexual differentiation, DSD. Okay? Malinaw naman, ano? Sige. So that is why the confirmatory test for CEH is requesting for a level of 17 OHP, which is elevated, expectedly elevated, and a low level of your cortisol kasi hindi siya makakapag-proceed dito. Okay, so clinical manifestations of CEH, as I've said, for females, they will mostly present with ambiguous genitalia, and then there will be a note of increased pigmentation, axillary, yung mga areola maiitim. Tapos, for those patients na, kumbaga, not really that toxic, like magde-develop ng metabolic crisis during infant period. So may mga patients din na nakikita na natin during adolescent days na yung nakakapag-survive. So they usually tend to present with precocious puberty. They are hirsute with menstrual irregularity and infertility. Lalo na pag mga non-classical CEH. Okay, so by the way, these patients, CEH, they tend to be, they have that affinity for a boy, like, mas gusto nila maging boy, because of that prolonged exposure to androgens intrauterine. So, parang they tend na parang boyish sila pag naglaro, they tend to use the toys for boys, yung mga guns. So, hindi sila maglalaro ng mga Barbie doll pag mga girls sila. So, we really have to understand them, yung mga CEH patient. Or not even kahit mga non-classical. Oo. So, may mga pinagdadaanan sila, especially during adolescent period. Kasi hindi sila maintindihan. May iyak na lang sila. Oo. Pero pag sinabihan mo naman sila na it's not your fault, pag na-explain mo naman na some, I think, hormones are actually, yun nga, dictating you to be that of parang ang affinity mo ay boy, so naintindihan din nila. So it's really important to educate din the parents on what to expect. Okay, baka mamaya kaisa-isang anak na babae gusto nila maging princess, tapos it turned out to be a prince. Diba? So they also have to understand. Okay, so this is just a Prader scale. This is a scoring system for grading the degree of genital masculinization. Kasi there are some patients, may mga ibang patients na stage 1 lang, may clitoromegaly lang, okay? Yung parang phallic length, medyo malaki. There are those patients on stage 2 with clitoromegaly with posterior labial fusion, okay? Ang stage 3 naman, only one urogenital orifice is actually available. Tapos yun ang problem natin because we have to subject this patient for surgery para magkaroon siya ng vaginal opening din. So actually treatment or management of this CEH is actually a multidisciplinary approach. So we have to refer to OB/GYN, we have to refer to surgeons for this repair. And then another clinical features, due to lack of cortisol, you will expect cool sac, quick cry, irritability and seizures, drowsiness, or even coma. And then due to lack of aldosterone, you will expect a vomiting, dehydration, failure to thrive, and hypotension, and even shock. So as I've said, the confirmatory test will reveal us a high level of 17 OHP, 17 hydroxyprogesterone level, and low level of your cortisol, hyponatremic, hypokalemic, hypoglycemic. So in most cases, tapos paired with your blood gas and metabolic acidosis, then you have that CEH, salt wasting, and metabolic or adrenal crisis. So that's an that's an emergency, really warrants emergency treatment. Okay, so for our case, the complete diagnosis is classical congenital adrenal hyperplasia, salt wasting, and adrenal crisis. Okay, so what about the therapeutic? So the patient is in adrenal crisis, you have to admit the patient, you have to collect blood for confirmatory test kung hindi pa siya nakunan, and then you have to assess the dehydration and start with T5 normal normal saline, which is actually the fluid of choice, D5 NSS, kasi nga hypoglycemic sila, tapos hyponatremic pa. And then you have to monitor BP, the blood glucose, the serum electrolytes level. And then you have to give the stress dose of hydrocortisone because yun ang kulang nila. And then give fludrocortisone, mineralocorticoid, but then fludrocortisone is actually not locally available. Pero minsan may nakukunan tayo mga patients, diba? We have one patient din na bumili lang tayo ng fludrocortisone sa isang CAH patient natin. And then we have to supplement it with sodium chloride. Okay? And of course, we have to treat the underlying infection. Kasi no matter how you give that hydrocortisone, your fludrocortisone, hindi pa rin mag-i-improve yan kung may ongoing na infection. So we have to treat that. And then the long-term treatment, of course, a lifetime medication of the oral hydrocortisone tablet. Medyo mahirap din to dati. Wala tayong makuha locally in the Philippines. Pero ngayon, merong paunti-unti na hydrocortisone tablet in Manila. Pero mahirap siya hanapin. Fludrocortisone still not available locally in the Philippines. So we have to order it like Singapore, in Hong Kong. Yan. Sodium chloride tablet is actually available naman. So sometimes, pag mga newborn pa or neonates pa, we have to give that sodium tablet, 1 to 2 grams per day. But later on, pag lumalaki na sila, ito yung mga sakit na pinapakain namin siya ng asin. Oo. Tapos nagki-crave talaga sila ng asin. So, ito yung, kahit nandito si Dr. Noel pinapakain namin siya ng chippy kasi yun yung mataas na na salt. Oo. Tapos nagki-crave sila. We usually educate the parents na dapat accessible yung asin anywhere. Oo. So, hindi sila pagbabawalang kumain ng asin. Kasi pag nag-crave sila ng asin, that only means na hyponatremic na sila. Okay. So, hydrocortisone tablet, 10 to 15 milligram per BSA and 2 to 3 divided doses. So, in the absence of hydrocortisone, kasi nga medyo mahirap din na mahanap yung tablet niyan. So, minsan pinapagamit natin sila ng prednisone. Pero usually we discourage using prednisone because of side effects, diba? So hydrocortisone pa rin yung the best. But in the absence of hydrocortisone, so we cannot just naman na waray iinumon na steroids kasi baka naman mamaya mag-metabolic crisis sila and adrenal crisis sila. So napipilitan tayo magbigay ng prednisone, but you have to take note that prednisone is actually 4 times more potent than your hydrocortisone. So if you are giving 20 milligrams per day of your hydrocortisone, like 10 milligrams in the morning and 10 milligrams in the afternoon, so you have to give, like, you convert it, pag prednisone siya, like 5 milligrams in a day. Kasi diba, 4 times more potent than your hydrocortisone. So 20 milligrams for your hydrocortisone and only 5 milligrams for your prednisone. Okay? So your prednisone is actually not a short-acting, so you can actually give this as once a day with meal. Okay, so next. This is a case of a 5-day-old boy and remarkable maternal and birth history. Normally, exclusively breastfed, BM 2 to 3 times per day, tapos NBS TSH of 80. So what case is this? Heidi. Hides? Anong case siya?
Two to three times per day. Congenital hypothyroidism daw.
Okay. So, anong clue mo dito? The TSH level of more than 80. Okay? So,
Yes,
in a patient thank you, Hides. In a patient who are exclusively breastfed, diba, 2 to 3 times per day, kunti lang yan, diba? Usually, maabot yan sila ng 6 to 8 times per day, diba? Pagkatapos niyang magdede, mapupo, diba? So, usually, ganyan ang presentation nila. Okay? Especially that the NBS showed us a result of PSH of 18. So our cutoff is actually less than 15. Okay? There are times na naka-indicate less than 12. Okay? But mostly, our laboratory would use the reference value of less than 15. So anything above that level will be considered positive. So this warrants confirmatory testing. Okay, so this is a typical case of congenital hypothyroidism. So clinical wise, most affected infants, about 95% appear normal at birth. So hindi mo yan makakakitaan talaga na, diba, as you have seen in the previous picture, diba, healthy baby, upgarnan, walang bahid-bahid ng symptoms. Okay? Nung malaman lang natin na NBS siya positive for TSH, diba? Elevated TSH. So usually they are normal at birth without any obvious manifestations because this is actually likely the result of a transplacental passage of some of the maternal thyroid hormones. Magkaka-problem tayo if those mothers also has hypothyroidism, not being treated with thyroid hormone supplementation. But because of the universal newborn screening, this allows us for early diagnosis and treatment of the patient. So approximately 5% of these infants, generally those who are severely affected, have recognizable features. Yung mga sinasabi ko na ang parents ay may problem din sa thyroid. Okay? Hypothyroid mothers, or yung iba naman, hyperthyroid mothers, not on medication, sa mga pasaway na mother na ayaw uminom ng gamot. Okay? So, at birth, the features would actually reveal wide fontanelles, wide sutures, and then you will take note of course facial features, flat nasal bridge, so large protruding tongue or macroglossia, causing the babies to be parang persistently opened mouth, and then with distended abdomen, sometimes with umbilical hernia. Umbilical hernia, mas note natin like 2 weeks na siya, umbilical hernia, kasi at birth normal naman talaga yan. So experience-wise, diba sabi ko, with umbilical hernia, we have received some referral from surgery department for CT clearance for a possible surgical repair, so only to find out it's a case of congenital hypothyroidism, diba? So for those babies who presented to you with umbilical hernia, please always rule out the possibility of congenital hypothyroidism. Kasi kahit pa ma-repair yan, hindi mo naman na-treat yung congenital hypothyroidism, wala pa rin yan, di ba? So usually, nag-i-improve naman yung umbilical hernia once the treatment is actually ongoing. Okay? So you will also note of a persistently prolonged, kumbaga, jaundiced baby, and then upon examination, bilirubin studies, so it's more of an indirect level, unconjugated bilirubin. And then, so this is actually secondary to immaturity of the hepatic glucuronil transferase, okay, brought about by the low level of your thyroid hormone. And then, those patients will also has the tendency to prolong gestation. So usually for more than 40 weeks gestation. Okay, they are macrosomic kasi matubig hira, nagre-retain ng fluid. So macrosomic babies, big babies. Okay? And those babies who are severely affected babies actually are generally described as good babies. They sleep more, often needing to be awakened to be fed. So, parang nakikinaturugla. So, parang the description of the mother will always be like, buutan niya nga baby, doktora. Oo, yan. Buutan nga yan kay waray, na ngayon niya, hypothyroid. No energy to, to cry. Okay, so, they are slow to feed, they have hoarse cry, may mga iba na babies na waray talaga hira voice. Parang na ganyan, ganyan lang. Pag impapatuok mo hiya. Okay. Part of your physical examination, you have to pitik the i-stimulate mo hiya pag-cry. So you will hear kung ano hiya cry. Force ba? May boses ba yung baby mo? Waray ba? Okay? So part of your physical exam. Okay? Pag medyo matagal na diri pa din niya na treat, so you can actually you will appreciate hypotonia, so slow reflexes, so depending on kung kailan mo siya nakita. So at times then you will also note a goiter, pero sobrang sobrang mga less than 5 to 10% lang ng infants, kasi usually the most common type naman, or the most common etiology of congenital hypothyroidism is complete absence of your thyroid gland, thyroiosis. So you will not expect an anterior neck mass kasi wala nga siyang thyroid gland. But for those patients with the etiology is secondary to dysharmonogenesis, then you will expect an anterior neck mass. Kasi nga, lolobo lang yung thyroid gland because of the stimulation of your thyroid stimulating hormone. Okay? So, but generally, over 95% of newborns with CH are asymptomatic at birth. Kaya, nakukuha lang siya or nakikita natin sa newborn screening. And thank you to the newborn screening. At least, it allows us to early detection and early treatment. So, we will be able to save babies. Okay, so what about confirmatory test? A low level of your FT4 and high TSH. Remember, newborn screening for congenital hypothyroidism will only detect the primary cause of hypothyroidism. So the defect is within the thyroid gland itself. We will miss those patients who are with central cause of hypothyroidism because TSH will not elevate. Okay? No, kahit ang FT4 mo ay abnormally low, but your TSH will remain as abnormally normal or abnormally low. So that will not be detected by the newborn screening. Okay? So pag may mga ibang symptoms siya pointing out to a hypothyroidism, kahit normal pa ang newborn screening niya, then you really have to investigate. Okay? So mga around 5 to 10% we will miss those babies kahit primary cause of congenital hypothyroidism for those babies born to mothers with hyperthyroid state, kasi minsan suppressed ang TSH nila. And then for those babies with central cause of hypothyroidism, yun ang hindi natin madidetect sa newborn screening. And then treatment, of course, thyroid hormone supplementation, levothyroxine, we usually start it at 50 microgram per day. So at 10 to 15 microgram per kilo per day. Okay? So another case, a 5-day-old boy, unremarkable maternal and birth histories, a 3rd day of life pulse-up, 4th day of life increasing sleepiness, difficult to arouse, spasticity of extremities, sweet smelling urine, and then NBS showed increased branch chain amino acids in plasma. So anong case ito? Intern naman. Kung sino makita ko, saglit, wala makita. Menchu! Sorry, Menchu, ikaw yung nakita ko na una. Menchu, you have that NBS showing us an increased BCAA. Menchu? Nagbabasa pa yata si Menchu. Sige. Menchu? Nandito si Rog. Rog?
Yes, Doc.
Anong case ito? Anong case?
Probably in MSUD.
Yes. You have that sweet smelling urine.
Smelling urine.
Typical.
Opo.
So thank you. And then on NBS, it showed an increased branch chain amino acids. So most probably this is a leucine level. Okay, so this is a typical case of an MSUD, which is an amino acid disorder caused by a deficiency of activity of the branch chain ketoacid dehydrogenase complex. So this is actually the most common IEM in the Philippines. Okay, so the long-term management includes protein limitation. We have to provide a special milk formula which is free of the branch chain amino acids, the leucine, isoleucine, and valine. in the form of BCAD. Okay? Oo, BCAD ang pangalan niya. We have BCAD 1 and we also have BCAD 2, just like your other formula. Okay? So, this actually provides special milk formula which is free of that branched chain amino acid. And confirmed MSUD patients are being supplied with this BCAD milk for free. Free siya for as long as may syempre supply. Oo. During the early month of lockdown, nagka-problema kami kasi nga parang walang pumapasok na BCAD supply. Oo. So, ang dami naming problem noon kung ano-anong binigay namin na mga high energy drink kasi hindi pwedeng kumain ng kung ano-ano lang. Dapat low protein, tapos hindi naman sila pwede sa mga regular formula. Nagka-crisis sila. So, during that month, ang dami naming nag-crisis din kasi wala pa silang food. Basta, medyo mahabang story ang MSUD. Okay? Sige. So, MSUD can also go into metabolic crisis. This usually occurs when patients are in catabolic state, which include intercurrent infections, so when the patient has trauma, or even during surgery. So, the principle of management is actually we have to reverse the catabolism and promote anabolism. Kasi catabolism, di ba, mag-aano sila ng amino acid, endogenous amino acid. So, ayaw natin yan. Okay, so we have to achieve a caloric intake of 120 to 140 kilocalories per kilo per day with a combination of BCAD formula and IV glucose and intralipid supplementation. So we have to lower the leucine levels to the target range, usually less than 300 or mas maganda kung nasa mga 200 lang ang level natin. Minsan kasi pag they are on a metabolic crisis, they can go as high as 1,000, 1,500. Yan, mga minsan nare-refer na kay Dr. Noel for dialysis. Okay, so we have to stop natural protein like breast milk for 24 to 48 hours. So talagang within that 48 hours, talagang dapat nakabikad lang siya or naka-intralipid infusion. Okay, so we have to gradually reintroduce the natural protein by the 3rd day of life. So during that day, nakapagbigay na tayo ng antibiotics, so may mga na-work up na natin siya. Okay, so yun nga, dahil ng sabi ko, in occasional cases, dialysis may be done. So time and again, we have to treat the underlying ongoing infection. Okay, so another case, a 7-day-old girl, jaundice on the 4th day of life with bleeding episodes, hypoglycemia, hepatomegaly with edema and ascites, renal tubular acidosis, and the NBS showed increased succinyl acetone and tyrosine. So anong case ito? IB. Mahirap ba ito na case? Oo, kasi we usually do not encounter this type of metabolic disorders. IB, alam mo? Try. Present ba si IB?
Yes po. PKU? Phenylketonuria? Try lang.
Oo. So, ang clue natin dito is the NBS showed a tyrosine, elevated level of tyrosine. So, this is a case of tyrosinemia. Okay. So, this is a case of tyrosinemia type 1, which is also an amino acid disorder, which is caused by a deficiency of fumarate acetoacetate enzyme, which is responsible in the final degradation of tyrosine. So, as a result of the metabolic block, toxic metabolites are formed, including the succinyl acetone. And these are responsible for severe disruption of intracellular metabolism of the liver and the kidney. Okay, so this is a case of tyrosinemia type 1. Okay, so treatment options for tyrosinemia include the use of pharmacologic agent, the 2-4-trifluoromethylbenzoyl, and 1,3-cyclohexanedione. So NTBC, and a combination of protein-restricted diet and phenylalanine tyrosine-free amino acid milk formula in the form of Tyrus. So this is also free for our patients. So another case is a 6-day-old boy born to non-consanguineous parents. An older sibling died as a neonate, being treated as sepsis, poor sac with lethargy, vomiting, leukopenic, thrombocytopenic on the 3rd day of life with metabolic acidosis, hyperammonemia, and being showed MMA in urine organic acid. Anong case ito? Si Paula. Pao, anong case kaya ito? PKU, MMA, biotinidase.
MMA, Doc.
Sige. So this is, yes, MMA. You have that MMA in urine organic acid, di ba? Yung NBS niya. So this is a case of a methylmalonic aciduria. So this is an organic acid disorder which is due to defect in methylmalonic CoA mutase, which cause the accumulation of methylmalonate in the body, which may be toxic to the brain and the kidneys. Okay, so treatment option, they should be maintained in a low protein diet, and to improve the quality of this diet may be supplemented with a special milk formula free of methionine, theanine, valine, isoleucine in the form of XNPV. Okay, so chronic oral administration of L-carnitine at 100 milligram per kilo per day, and then giving of metronidazole, an antibiotic that inhibits anaerobic colonic flora, and which has been found to be specifically effective in reducing urinary excretion of the propionic metabolites. You also have to provide with a supplement with vitamin B12 complex. Okay, so this is a case of an MMA. So another case is a 6-day-old girl, has seizures and hypotonia, an eczematoid skin rash, pabalik-balik, and then decreased biotinidase on newborn screening. So this is a classic type of biotinidase deficiency. So for those patients na may recurrent na na especially perennial rashes, then you have to rule out the possibility of the biotinidase deficiency. This is an organic acid deficiency which results in an inability to recycle endogenous biotin, which means that the brain is unable to recycle biotin adequately, leading to decreased pyruvate carboxylase activity in the brain and accumulation of lactate, which in turn causes the neurologic symptoms. Okay, so mabilis lang to siya matreat. You just have to buy biotin. You have to give 5 to 10 milligrams per day. So this is the long-term management. Yes, you have to give biotin tablet. Okay, so another case is a 5-day-old boy who came in with who presented with vomiting, lethargy, and then went into deep coma, and then on physical examination, you noted hepatomegaly with increased citrulline levels, hyperammonemia. So anong case ito? So this is a case of citrullinemia. So this is again an IEM resulting from deficiency of arginosuccinate synthetase, an enzyme present in all tissues but the level of which is highest in the liver. So where it functions in the urea cycle, and arginosuccinate synthetase is an enzyme that converts citrulline to arginosuccinate. So the absence of which causes an increase in the plasma citrulline and ammonia levels. Okay, so for the treatment option, most patients require a low protein diet, and arginine should also be supplemented to replace what is not actually being synthesized, and giving of sodium benzoate at 250 to 500 milligrams per kilo per day will help in the elimination of toxic chemicals, ammonemia. Okay, so, pero wala pa tayong case sa Divine Word Hospital. So I think this is the last case. So sa 7-day-old boy not feeding well the night before, received at the emergency department with hypoglycemia, had an older brother who died at 3 months of age due to vomiting and hypoglycemia, and note of increased C8 on newborn screening card. So anong case ito? last, magtatawag ako, intern naman, intern. Sino nag-pray kanina? PGI Hitalado ba? Tama?
Yes, Doc.
Sige. Sige, anong case ito?
Galactosemia, Doc.
Galactosemia. Actually, this is the case of a fatty acid oxidation disorders. Diba? Your patient presented with hypoglycemia kasi hindi na siya nag-feed the night before. Okay, diba? As I told you kanina, FAOD or a fatty acid oxidation disorder should not be placed on a prolonged fasting. Okay? So, nag-hypoglycemia siya. So, this is a case, itong FAOD disorder nga, in which there is a defect in the fatty acid metabolic pathway. Hence, patients cannot metabolize fats properly. So, diba, during hypoglycemia, sometimes breakdowns of fats, diba, doon tayo kumukuha. But then, kasi hindi siya makapag-metabolize ng fats, then, yan. This will actually lead to signs and symptoms. Okay? Hindi niya magamit ang fats niya. Okay? So, this usually will present us with hypoketotic hypoglycemia. Okay, so the treatment options, it is essential to prevent any period of fasting which would be sufficient to require the use of fatty acids as fuels. And this can be done by simply ensuring the patients have adequate carbohydrate feeding at bedtime and do not fast for more than 12 hours overnight. Okay, so for young babies, they should be fed every 3 to 4 hours. So with late night fed continuing until about 9 months of age, and they should not be fast for longer than 6 hours, 6 to 8 hours. Okay? So during and recurrent illness, when the child has poor appetite, tapos low energy or excessive sleepiness, tulog ng tulog, tapos with vomiting and diarrhea or infection or fever, so care should be taken to give extra feeding of carbohydrates during the night and inform the doctor or the attending physician for the sick day regimen kung hindi pa sila na-admit. So, which mainly consists of that high energy drink. May formula tayo for that high energy drink. This is actually a combination of mga fruit cocktail. So, may yan, may ratio and proportion. Okay, medyo mahal din kasi bibili ka ng fruit cocktail. Diba? Oo. So, what are the outcomes? So, it's critical to screen babies as early as possible to prevent the negative effects of these disorders. And indeed, identifying with one of the disorders is beneficial because early diagnosis and treatment can prevent consequences such as recurrent illnesses, development of disabilities, or even death. Okay, so CH, pag hindi mo siya na-treat, then you will expect severe growth and mental retardation, CAH and MSUD, death, and PKU, severe mental retardation, D6PD, severe anemia, and kernicterus. For other metabolic disorders, amino acid acidopathies, mental retardation, coma, death from metabolic crisis, likewise for organic acid disorders, your fatty acid oxidation disorder, cystic fibrosis, your biotinidase deficiency, lahat sila, if not detected or not intervened earlier, so they will minsan yun na, mental retardation, or pag hindi mo talaga naabutan, this coma or death. Okay, so that's how newborn screening is important to us, so especially to those newborn babies. Okay, I think that would be my last slide. So actually a simple drop of blood really saves lives.